Good evening, all. I, Shreya from Torrent Pharma, welcome you all to the Spine series, a noble endeavor by the team of Stavya Spine Surgeons. Thank you all for taking out time from your hectic schedules and joining us live today. Today is the conclusive session for the Spine series, and we plan to discuss the summary of all the topics that have been covered. Before I move forward, let me take you through the legend of Stavya. Stavya literally stands for Lord Krishna, the first spine doctor in the world. He treated Kubja, a hunchbacked woman from Mathura. She was walking across the streets of Mathura while she saw Krishna and she offered him the sandalwood paste. Overwhelmed by her devotion and sincerity, Krishna pressed his foot on her toes and lifted her chin with 2 fingers. It is said that the hunchbacked Kubja stood straight. The name Stavya has henceforth continued. Similar passion, Stavya stands today, helping thousands of patients lead a better life. The Spine series is an educational effort in the same direction. Today is the 9th webinar of the series for all of us. Through the educational endeavor, the Spine series. Stavya, along with Shelcal, has been oriental in spreading out roots of knowledge both nationally and internationally. As the challenges pertaining to spine health arose, so did the new possibilities. And in an effort to understand the same, we always had an expert panel who shared their wealth of experience with us. The journey started way back in August with the first webinar on basics of spine. Thereafter, many core topics covering the subject were taken up every alternate Thursday, like osteoporosis prognosis and treatment options, lumbar degenerative disease, cervical degenerative disease, ankylosing spondylitis, and advances in spinal surgery. Today, in the month of December, we are at the conclusive session for the Spine series. We plan to cover all the essence of the 8 sessions into this one single episode. So before we begin the program, let us all welcome our esteemed moderator for the day, Dr. Bharat Dave. Welcome, sir. Dr. Bharat is a senior spine surgeon, and today he shall be speaking on the topic cervical degenerative disorders. Dr. Dave holds more than 30 years of experience. He is an eminent speaker at all the national and international platforms. He is also the reviewer for many reputed journals, like the Journal of Orthopedic Trauma, the Indian Spine Journal, the Asian Spine Journal, and the Global Spine Journal. Welcome, sir. I would also take this opportunity to welcome our speakers for the day. Dr. Ravi Ranjan Rai, who would be talking on lumbar degenerative disorders, Dr. Ajay Krishnan, who would be speaking on deformity, Dr. Shivanand Mai, who would be talking on osteoporosis prognosis and treatment options, Dr. Devanand, who would be talking on tumors, and Dr. Birju Vyas, who would be discussing about the ankylosing spondylitis. Welcome all of you. I now hand over the session to Dr. Bharat to kindly take us forward.
Greetings from Stavya Spine Hospital. I am Dr. Bharat Dave. Today's webinar is to sum up about the spinal disorders. I would like to start with the disclaimer. This is purely an educational activity to introduce the different spinal conditions and to increase the awareness and treatment that will vary from case to case. Would like to start with normal biomechanics. We all know spine is a series of vertebral bodies and in between there are discs. In the cervical spine, we have 7 vertebra and we know that it can be compared with the train and 2 compartment with the spring in between which absorbs the load, and that gives us the unique facility to the body to have the mobile segments, multiple mobile segments. At the same time, they provide the rigidity As you can see in this MRI, which is flexion and extension, there is significant coiling of the ligamentum flavum at the back of the neck. And we can see that folding and unfolding zone, which makes unique structure of the cervical spine. Coming to the most common problem which we see nowadays using the mobile, like in the lumbar spine, the load will change according to the movement. Same way in the cervical spine, the load will change. If the neck is straight, it is about 10 to 12 lb, but when the neck is flexed to 60 degree, the load goes to 5 times more. So any activity that is done with the neck in flexion should be avoided in order to reduce the load in the neck in the cervical spine. Coming to the systemic division of the problem related to the neck, we can first start with the axial neck pain. We can also have the second division will be radicular pain, pain in the arm, and third will be the myelopathy. So these are the three common problem and the division which we can have for the neck problem in the cervical spine. What is the natural history of the neck, axial neck pain? And if you look at the cervical spine degeneration, the natural history, it is most of the time self-limiting when you consider the axial neck pain. It is something that happens to practically every one of us today, tomorrow because of the neck and the disc degeneration. But what we should look at is the flexion extension movement and the load and the deformation. As age increases, this movement will reduce. Trying to move more, it will hurt and it will lead to more degeneration. So we should be considering the static and dynamic both, and that can predispose the injury that can give rise to radiculopathy and myelopathy as well. Coming to the radiculopathy, pain in the arm, that is again because of the sensory and motor changes that can occur because of the compression of the nerve, and that can be quite painful. And we look at the disc prolapse, which is commonly seen in the younger age group, and at the later age the hard disc also can give rise to radicular pain. In the younger age, it resolves in 90% plus cases. Most of the time it resolves with the medication. We need to give different combinations of the medicine starting from anti-inflammatory to the gabapentin group. We should avoid exercise when patient has significant and severe pain. We should avoid giving traction. Sometimes traction is advised, but then if first or second sitting of the traction increases the pain, that we should not continue. Or patient may develop neurological deficit if we give traction in the acute phase as well. Another thing which we always advise that patient in acute neck pain with radicular pain, they should use the pillow. If you do not use the pillow, because then there will be extension of the neck and the pain is likely to increase. So what one should do, one should use the pillow because that will keep the neck flexed and that will open up the space for the nerve root. So which is the most common myth in this society. This is how the disc prolapse will look like, decrease in the height of the disc, and that will compress the nerve root and the spinal cord. Another division of the symptom is the myelopathy, which is characterized by the long trek signs. Patient will have problem related to the walking and day-to-day activity. This is a classic example of myelopathy. 55-year male presented with numbness of all the four limbs and significant imbalance. And as you can see here, there is significant compression at 3-4 and 5-6 and 6-7 level. So this is the classic MRI picture which we will see as age increases. What is the natural history of the myelopathy? Myelopathy, we consider it as a surgical disease, and once the cord compression develops, cord changes continues to progress, and patient will end up with further neurological deficit. The classic definition will be spastic gait. If patient comes too late to us, initially patient will have clumsiness in the hands, and there may be atrophy of the muscles, of the small muscles of the hand. And at the end, patient may end up with the sphincter disturbance as well. This is something which is worth knowing and one should consider. These are the Newton grade, gait disturbance. So initially patient has no difficulty in walking, patient will have numbness and tingling only, but then it will come and go. Afterwards patient will develop some gait imbalance, patient will have persistent tingling and numbness. In the grade 3, patient will have gait abnormality and that patient may not be able to do his or her job, and afterwards patient will be able to walk with the assistant in grade 4, and in the grade 5 patient will come in the wheelchair and may have the bladder bowel involvement as well. So as compression continues to progress or compression remains static or even dynamic, patient will end up with from grade 1 to grade 5. So this is 100% preventable and we should act in the early stage of the disease and early stage of the compression. This is classic example, as you can see here, significant compression at 4-5, and here we have done the decompression and that shows adequate decompression. But just see these chord changes are there, and these chord changes will leave some neurological deficit, some neurological involvement, and mainly the sensory. Progression of the cervical spondylotic myelopathy, 75% of the patients will have stepwise progression. This is very important to understand. Patient may have symptom of 20-30%, then patient will become static, then afterwards after few months or maybe few weeks patient will have some progression, then it may become static. So patient won't realize that there is progression of the disease. Most of the time patient they ignore and they usually start adjusting. So this happens in 75% of the cases. In 20% of the cases there is slow progression. Most of the patient they will understand this and they will be able to judge that I'm gradually worsening. But in 5% of the cases, that is where we really need to tell the patient, because then there is rapid progression and patient will end up with quadruparesis, significant neurological worsening, and from grade 1 to 5 it won't take long. So when we operate or when we see myelopathy patients, we advise them what are the chances of for you to recover. So early age, if there is significant worsening, then probably they improve. But then if it is a later age, more than 60, then that is a poor prognostic sign. 6 months plus duration, usually they do not respond well to the considered treatment. Vertebral body and canal ratio. This is what I think everyone should understand, that when the canal size is narrow, which is less than 0.8%, then they are the one, they usually will have lot of issues, and we really need to look at the lower area as well, dorsal and lumbar. And cord compression after surgery, when it is less than 0.4, I think that's where one can say that it's a poor prognostic. Operating procedure. Why operation and what operation? Well, I think we should really decompress the spinal cord. But when you look at the radiculopathy, they usually have the good outcome with the surgery. When there is neurological deficit, we should act immediately. And sometimes we do the disc replacement as well. That is called total disc replacement. And as you can see in this case, we have put the new disc. So when there is radiculopathy, when there is motor power loss, and when there is significant pain not responding to conservative treatment more than 6 weeks to 12 weeks, then we advise them surgery. That is for the radiculopathy. Myelopathy per se, it is a surgical disease, and we usually advise the patient to get operated early in cervical degeneration. This is very important to understand. These are the mimickers of the cervical spine problem. One of them is the frozen shoulder. When there is adhesive capsulitis, patient will also have some neck pain, radicular pain as well. So very important to understand that the adhesive capsulitis or frozen shoulder can mimic the cervical problem. Another one is the thoracic outlet syndrome. When there is extra first strip or when there is congenital anomaly or scanellaris muscle which is compressing, that can give rise to thoracic outlet syndrome and classic radicular pain. Another one is a fibromyalgia, multiple tender spots, particularly seen in the female patients where there is myofasciitis, and that will mimic like trapezitis, and they will also have multiple tender spots. Another one is the neurological viral inflammation of the nerves that can also mimic the classic radiculopathy as well. As shown earlier, one has to look at the ergonomics, and as we discussed that neck flexion increases the pressure in the neck vertebra and the disc. So very important, kitchen at any workplace is 2.5 feet height. Now somebody who is tall, for them the neck flexion will be more, and hence we really should try to understand the ergonomics and may use something to raise the platform, because each one of us, each one of the lady working in the kitchen would have different height. Similarly, boys, when they are using mobile, they usually use it like this, and particularly those who are working self-employed people or working for sewing. So that sort of activity also can give rise to a lot of neck pain as well. So all these ergonomics should be discussed and taught. And we as a surgeon see this quite frequently happening as well with us. And we usually end up damaging our neck and the disc prolapse too. What are the exercise one should do? 5 quick exercise. Chin tuck. So meaning, one should really have this sort of movement, so that will strengthen the muscles. One can have the isometric exercise that will strengthen the muscle as well. One can do some stretching that will also help, and one can really need to strengthen the pectoralis and the girdle muscles as well. And shoulder squeeze. These are the few exercises which will certainly help and which should do by day-to-day activity. I strongly advise not to do rotation exercise unless doctor has advised you, and particularly after certain age, rotation will precipitate more pain and radiculopathy as well. So when to consult the doctor, we should really have the discomfort which is more than few weeks with radicular pain and imbalance in the walking, tingling numbness that also persists, gait disturbance that should be the consultant, one should consult the doctor. Self test you can do the neck rotation and extension of the neck, and the arm pain starts. Romberg test. Close your eyes with the keep the feet together, and if patient develops swaying side by side or yourself swaying side by side. Grip test. Do the grip test, and if you cannot do fast, or check the lower limb power. These are the red flags where one should really consult the doctor or one should refer to the spine consultant. And the most important is, in order to avoid the recurrence of the pain, once the disc prolapse has occurred, one should try and avoid the recurrence of the pain, and that one can do only with exercise. So know your pain and act accordingly. Know your ergonomics and act accordingly. This is the message which I would like to give at the end. Thank you very much for your questions hearing. Thank you.
A very good evening to everyone. I am Ravi Ranjan Rai and I'll be discussing about lumbar spine disorders. Lumbar spine disorders can be mainly grouped as degenerative, infective, inflammatory, and neoplastic. Degenerative are those related to age-related changes. Inflammatory includes ankylosing spondylitis, which would be discussed by Dr. Birju Vyas, and tumors or neoplasms will be discussed by Dr. Devanand. In our previous lecture on basics of spine surgery, we have seen how human has evolved from being quadruped to the modern human who walks on two legs. However, this change has been brought about mainly because of the spine, which is now stands erect and bears the most brunt of being straight and walking on two legs. This has resulted in more degeneration of the lumbar spine. We have seen different curves being have been provided to the spine to make it flexible along with protecting the spinal cord. The curves progress from being a single C-shaped curve in a fetus. The first posteriorly concave, that is lordosis of the cervical spine, appears when the child starts head lifting, and the lordosis of the lumbar spine appears when the child starts standing, and this is how the curves of the adult look like. The curves again change with progressively with age, becoming kyphotic because of senile kyphosis along with degeneration. Along with bones, we have muscles which are all around the spine and which can be strengthened to change the biomechanics and the dynamics of spine. Let us have a quick overview of the lumbar intervertebral disc. We have seen the vertebral bodies are separated by intervertebral disc, and most of the degenerative pathology begins with the disc degeneration in the lumbar spine. The disc being avascular and aneural structure, any damage to the disc takes more time to heal. The intradiscal pressure increases with posture and being maximum on sitting and bending forward or slouching while lifting weight. Even on sitting, the intradiscal pressure changes with the posture. Sitting with forward bending puts maximum stress on the lower lumbar discs. This is how the normal disc looks like, comprising of outer annulus fibrosus and inner nucleus pulposus with the neural structures behind it. When the disc prolapses or protrudes, the annular fibrosis gets torn and the disc material comes out, thereby generating inflammatory reaction as well as causing mechanical compression on the neural structures, leading to the signs and symptoms which we see along with disc prolapse. The signs of symptoms of disc prolapse usually correspond to specific nerve root which gets compressed because of the disc prolapse. For example, if the L4 nerve root gets compressed, the pain is seen radiating along the L4 dermatome and the weakness will be seen along the L4 myotome. Most of the cases of lumbar disc prolapse can be managed conservatively with rest, medicines, physiotherapy, or root block injections when required. However, those cases where there are bowel bladder symptoms like increased frequency of urination or dribbling of urine, urinary incontinence, or progressive neurological deficit or persistent pain which severely affects activities of daily living, these cases, which comprise less than 10%, would need surgical intervention. Surgical intervention may be in the form of endoscopic discectomy, microlumbar discectomy, or a fusion surgery, which the surgeon decides based on the patient's symptoms, the radiology, and the patient's demands. However, the red flags to be remembered is those pain which presents with more than 6 weeks duration, the age of the patient being less than 18 or more than 50, those which have a history of trauma, those patients presenting with constitutional symptoms like fever, weight loss, loss of appetite, night pain, or progressive neurological deficits. These are considered to be red flags and must be investigated thoroughly. Symptom Another common presentation is lumbar spine stenosis. Here we see a 70-year-old female presents with both lower limb heaviness on standing and walking for more than 5 minutes. She is comfortable on walking with a shopping cart and she has a stooped forward gait. This is typical of lumbar spine stenosis, and as we can see in this MRI, we can see stenosis at L4-5 level on axial as well as the sagittal views. Lumbar spine stenosis, when presents with only minimal back pain, is managed conservatively. Those presenting with radiculopathy or radicular symptoms, some of them may need surgery. However, those presenting with bladder symptoms or progressive neurological deficit would need surgical decompression plus or minus fixation as required. Another common presentation, a 40-year-old male asthmatic on long-term steroids presented with low back pain, which was mechanical type, more on sitting and standing. There was no history of fever. However, the MRI revealed spondylodiscitis-like changes at L3-4 level. So this is of course an infection, and the basic principles of infection is first to confirm the diagnosis with the help of blood investigations, imaging, and most importantly biopsy, because biopsy gives us the organism, and depending on the culture and sensitivity report we can appropriately treat the organism. The antibiotics, as per sensitivity, being the mainstay of treatment. Surgical treatment may be required if it is associated with progressive neurological deficit or intractable pain. Most common infection that we see in spine is tuberculosis. The main medical treatment of tuberculosis comprises of 12 to it lasts for 12 to 18 months. First line drug includes 4-drug regimen. Dosage is based on weight. When surgery is required in cases of infection, when there is progressive neurological deficit, intractable pain, in cases of deformity, in cases in children when it presents with spine at risk sign, or for wound wash debridement and for surgical site infection. The case that we had seen of a 40-year-old asthmatic was managed with a single level fusion surgery along with biopsy, which the culture came out to be Staph aureus and was treated with antibiotics as per sensitivity. So the red flags that to remember again is those patients presenting with pain of duration more than 6 weeks, age of the patient being less than 18 or more than 50, those having history of trauma, those presenting with constitutional symptoms like fever, weight loss, loss of appetite, night pain, or with progressive neurological deficits should be considered as red flags, and these patients must be investigated, referred, and may need urgent intervention. Thank you very much for your attention.
Good evening. I welcome all viewers to this webinar. I am Dr. Shivanand Mahi from Stavya Spine Hospital. Today I am going to speak on osteoporosis and the latest treatment options. So the number of clinical cases what we are seeing in our clinic is like tip of iceberg. So we actually diagnose less number of cases from the community and treat them. The more of the cases are which are in the community are undiagnosed, and sometimes they directly present with the osteoporotic fracture. So it has been estimated that more than 200 million people are suffering from osteoporosis all over the world, and it is most commonly seen in women as compared to men. And in Indian scenario, it is estimated that the prevalence of osteoporosis is around 24.6% in men and 42.5% in females. Recently, in this article published in Lancet in 2019, it has been said that osteoporosis fracture increases with the increase in age of females after 55 years and in males after 65 years, and it increases the mortality and healthcare cost related with the treatment of these patients. Whether we like to know about osteoporosis or does not, but we have to think about it, remember, try to diagnose and treat at the earliest to decrease this morbidity and mortality associated with these pathological fractures. So this osteoporosis is like silent thief. It is like termite. So it erodes the bone from inside, and from outside everything appears fine, but the microarchitecture is affected and it becomes weak, and whenever fracture occurs the bone crumbles like this, the termite eaten wood. So it also becomes difficult to reconstruct or repair or put the plate, nail and reconstruct the fracture. So we need to act before this fracture occurs and treat the osteoporosis at the earliest. So it is a systemic skeletal disease characterized by reduced bone mineral density and disruption in the bone microarchitecture. So there is less of bone formation and more of bone resorption. Because of this imbalance, the bone becomes weak. So the types of osteoporosis are like primary osteoporosis, that is type 1 is postmenopausal, type 2 osteoporosis is universal, and after peak bone mass it has been attained, it will start both in men and women. And secondary osteoporosis, it has got a big list of causes like lifestyle changes, genetic and endocrine disorders, gastrointestinal disorders, hematological disorders, neurological and musculoskeletal factors, rheumatological disorders, and drugs. As I have said earlier, osteoporosis leads to morbidity and mortality in elderly people. With increased life expectancy, we are going to see more number of cases with osteoporosis, and it affects 1 in 3 women and 1 in 5 men after age of 50 years, and the healthcare cost associated with more in osteoporotic fractures, and it could become a major public health problem in future. And male osteoporosis needs a special consideration which was not considered much before, and dual energy X-ray absorptiometry is the investigation of choice at present. So this is the DEXA machine, where it is a special X-ray machine where it calculates the BMD at spine, femoral neck or wrist, and according to the WHO classification T score, we can start the treatment to the patient. So coming to the symptoms, clinical features of osteoporosis, as you can see in this couple, gradually the height of the lady is decreasing. So why this happens? This is because of the multiple compressions of the vertebrae, compression fractures of the vertebrae. So in first 2007 she had only one vertebra compressed, then gradually the adjacent vertebra started getting compressed, and it will lead to kyphotic deformity. So this compression of the vertebral bodies and kyphotic deformity causes the decrease in the height, which is a significant clinical feature. So coming to the other symptoms, most of the patients present with spontaneous fractures or fractures following minor trauma, and vertebral fractures might occur during the daily activity. And this one vertebral fracture is the predictor of the future fracture, either at the vertebra or at the other side. So this is the Prax tool. Here, putting all the details of the patient and BMD, we can calculate the risk of fracture in next 10 years. So higher the risk, we should start the treatment at the earliest. So this is the classification of the osteoporosis by WHO, and this is the graph. The green indicates normal bone, and the -1 to -2.5 indicates osteopenia, and less than -2.5 of T-score indicates osteoporosis. And when a patient presents to us with less than -2.5 of T-score with a fracture, it is called as established osteoporosis. So coming to the treatment, mainly the non-pharmacological treatment is adequate calcium supplementation with vitamin D supplementation, weight bearing exercises, smoking cessation if at all, limitation of alcohol or caffeine intake, and in elderly we should take care of fall prevention techniques. We should see that elderly people does not fall, because once the fracture occurs, the morbidity is very high. So the main aim of this treatment is to change the remodeling balance of the bone. So in young adult there is remodeling, resorption and bone formation, so it fills the cavities. So in age related bone loss, the resorption is more but the bone formation is less, so it goes into negative remodeling balance. With the therapeutic approaches, when we give anti-resorptive, actually they reduce the resorption to the half. When we give anabolic drugs, it causes modeling based bone formation, that is along the stress lineage the more bone formation will be there, and overall it gives rise to anti-resorptive and anabolic, they give rise to increased remodeling and positive remodeling balance, making the bone strong. So main aim of this pharmacological therapy is to reduce the fracture risk in elderly people. There are two groups, anti-resorptive like bisphosphonates, estrogens, calcitonin and denosumab, and anabolic steroid only one, that is teriparatide. So coming to the zoledronic acid, it is a nitrogen containing third generation bisphosphonate. So it is given as 5 milligram intravenous infusion annually. So mainly we should see that the patient's creatinine clearance should be fine. If it is less than 35 ml per minute, this drug should not be given, and it has shown promising result of increase in BMD at lumbar spine and femoral neck, and also reduction in the new fracture rate up to 70% in spine and up to 41% in femoral neck. Teriparatide is a parathormone analog which is given as a bolus dose daily, morning early, subcutaneous. It comes as a pre-filled syringe with dose of 20 micrograms. Okay. So every day morning it is taken, and it stimulates the osteoblast, and it is the only drug which helps in formation of the or increases the formation of the newborn in osteoporotic people. Another newer drug is the denosumab, which is fully human monoclonal antibody that binds to the cytokine rank ligand, and it inhibits the osteoclast completely from resorption activity. The dose is 60 mg subcutaneous every 6 months, and it should be supplemented with the calcium and vitamin D before giving this denosumab injection. So this is the pictorial diagram showing the drugs where they act. The teriparatide mainly acts at the osteoblast, and other drugs they inhibit the osteoclast activity and reduce the resorption. So these drugs which are most commonly used, the first line drug is bisphosphonates, alendronate, risodonate, zoledronic acid. They act at vertebral, non-vertebral and hip level. Denosumab also, by inhibiting osteoclast, acts at vertebral, non-vertebral and hip region. But teriparatide, ibandronate and roloxifene have got very good result at vertebral and non-vertebral level, but does not have any effect at the hip joint. So the take-home message is osteoporotic fractures carry a substantial burden of morbidity and mortality once it occurs in elderly people. With early diagnosis and appropriate pharmacological therapy, we can prevent these osteoporotic fractures. And anti-resorptive drug as a first line, bisphosphonates as a first line drug in osteoporosis, they give very good result, along with other drugs like denosumab and estrogen supplements. Denosumab, this is a newer drug, very convenient for the patient for this one administration, 6 monthly injection, and it gives very good result, and it leads to earlier increase in the BMD in the patients. The teriparatide has got very promising role and helps in newborn formation. And combination therapy, we can start 2 drugs at a time and stop 1 drug after 2 years, and we can switch to other drugs. So the combination therapy and continuation of therapy leads to control of the osteoporosis. If we stop any drugs suddenly, there might be again decrease in the BMD and chances of fracture will be more. So we should see that any drug is not stopped abruptly, and we should monitor the osteoporotic status, that is the BMD of the patient, on regular interval, like yearly once during the therapy and even after the anti-osteoporotic therapy. Thank you for your kind attention.
A very good evening. Myself, Dr. Devanand, Stavya Spine Hospital and Research Institute consultant. We are going to talk something about spinal tumors. I have basically divided the spinal tumors into primary bone tumors, metastatic spinal tumors, and intradural spinal tumors. We are going to talk about each of them in detail now. So primary bone tumors are further divided into many types. Few of the examples as I have shown here, the cervical spine C2, you can see that there's a tumor, the pathological fracture. This we have operated and found it out to be giant cell tumor of C2 vertebra. In the second example, you can see that there was a bony tumor arising from the transverse process of cervical vertebra. This was a osteoid osteoma. And the MRI scan, as it shows, normally hemangiomas are seen many which are asymptomatic, but this case was a hemangioma with a pathological fracture where you can see the pathological posterior cortex break. So this is also a primary bone tumor. In the same way, we have many tumors that affect the spinal bones. Chordoma is most commonly seen in the sacrum. The second variety is the metastatic bone tumors, metastatic spinal tumors, where the primary may be in the lungs, the prostate, or in the breast. So these are the most common metastatic tumors, which the tumor extends to the spine, and it may cause osteosclerotic or osteoporotic pathological fractures. The third variety is the intradural tumors. Among these, we have intradural extramedullary and intradural intramedullary tumors. So most commonly we operate schwannoma, meningioma, neurofibroma. These are intradural extramedullary tumors. In the same way, we have other tumors which are intramedullary tumors also. Most of these are dealt by the neurosurgeons, but it's Tavya. We operate these cases successfully under neuromonitoring. So what would be the clinical features? Most commonly, symptoms are vague regular symptoms like neck pain, back pain, radiating pain along the nerve root, paresthesias when the cord is involved. Sometimes the patients come with weakness of both the lower limbs or the upper limbs, gradual onset and gradually progressing. Few of the patients, they even come with bladder bowel symptoms. So on examination, we find the tenderness. Occasionally, we have restricted movements of the affected spine. We examine the power, sensations, and reflexes, which give us a fair idea about the spine involved. So once it comes to the investigations, the basic X-rays are always a must. They give a fair idea about the bony tumors of the spine. As you can see here, the sacrum, the lower part of the sacrum, there is an osteolytic lesion on the right side. And once it is a confirmed or a doubtful bony tumor, we go for the next investigation of choice for the spinal bony tumor, that is the CT scan. The CT scan gives us an idea about the osteolytic tumors or the osteosclerotic tumors. It gives a fair idea about the extent of bony involvement. And for further confirmation and the soft tissue involvement, we go for the MRI scan. Sometimes we do get other scans like bone scan and PET scan to know the involvement of the affected area, as well as to know whether it is a hot spot or a cold spot, and also know the other parts of the spine which are involved, or a metastatic tumor in which other part of the body is involved. So management, especially in spinal tumors, is always a multidisciplinary approach. It's not a one-man show. Oncophysician, oncosurgeon, radiologist, radiotherapist, and pathologist. All of this, they work together to give the best outcome to the patient. So the modalities of operative management are surgical modality, where we have the excision of the tumor mass. It could be en bloc excision or it could be a partial excision. Further, few of the tumors require radiotherapy, chemotherapy. All these treatment modalities depend upon the type of tumor, the extent of neurological recovery which is expected, and also the survival period of the patient. So these all require a careful planning and a multidisciplinary planning. For example, in this case, which was a huge sacral tumor and it was a biopsy proven sacral chordoma. So we operated as a team. We planned the incision and the approach. The complete removal of the tumor is always the aim, because even the partial remnant of the tumor within the body gives rise to recurrence, which is very difficult to handle, especially in tumors where there will be a lot of fibrosis and adhesions of the tumor mass, and it is difficult to identify in a recurrent tumors and revision surgeries. At Stavia, we have technology. We use OARM navigation to guide the extent of bony tumor removal. And also we have safe instrumentation placed under this technology. After surgery, the postoperative management plays a crucial role because it all depends upon the neurological recovery of the patient. We often take postoperative imaging in terms of CT scan and MRI to know the extent of tumor removal as well as the chances of recurrence, which is already explained to the patient. Aggressive physiotherapy plays a main role, and above all, family support is very important. These patients are usually advised to get a regular postoperative visits with a long-term follow-up for the better outcome. So all in all, the multidisciplinary approach in a spinal tumor case is very important. Thank you.
Good evening, everybody. Deformity. Natural curves, the thoracic kyphosis, the lumbar lordosis, cervical lordosis. It's very well known. At the same time, coronally we are very straight, and if there is an alteration, it is called scoliosis. An alteration in the sagittal plane is called kyphosis. These are the basic things. A truncal shift can occur that is painful and usually temporary. A sagittal misalignment can occur, and a spondylolisthesis high grade. These are all parts of the deformities, and the spine disorder presentations are either pain, a neurological deficit, or a deformity. And why we are talking about deformity is the cosmos is involved in it. There, because of the instability or the malalignment, more amount of energy expenditure is required by the body to keep it straight and agile, mobile. Vital organs space may get compromised, like the thoracic cage, or the abdominal visceral space become reduced. That's why it needs to be addressed. Neurological presentations can be there, which is though rare, and early degeneration is expected because of malalignment and abnormal loading of the facets and the disc. Scoliosis can be congenital, can be neuromuscular, can be degenerative, which is in the elderly side, and it can be idiopathic, which can present as an infant, as in a prepubertal age, or an adolescent age, or as an adult. So, where you don't have a reason why it happened. And the presentations are diagnosed many times prenatal USG, sometimes diagnosed at birth with skin stigmatas and other things which is visible or associated conditions. You should look for hidden things like tuft of hair. You have to look for the fatty lower back, wherein you can see a small amount of fat which is excess of the routine thing, and that should make you suspect that there is something wrong in the spine. This type of small healed sinuses, or there can be small openings which may be there just in the sacrococcygeal region, and that should also give you a warning that there can be something which can be wrong inside. Neuropathic ulcers, clawing of toes, cavers, wasting of the limb, that should all give you an idea that there can be something going on inside the spine. And in cases of congenital scoliosis, always look for other system anomalies which is present in 60% of cases. So that should be very much known. Syndromic associations can be there. Congenital curves are of varying types, and they are either for failure of formation or failure of segmentation. And there are certain congenital vertebrae which you should not wait even if you are directed. If you have say identified it early, you may need an early intervention that includes unsegmented bars like this. One side it is completely fused, or an unsegmented bar on one side with hemis on the other side, or multiple type of vertebral problems. They can cause real big things. So you should know which can progress and which cannot progress. And at the highest risk of progression is at the growth spurt. So you should be able to identify the growth spurt. You should be able to compare the achievable height which is left and at what age, and that is dependent. In the adolescence it is maximum, which is identified by the menarchal status. The actual growth occurs 1.5 years previous to the menarche. Breaking of voice, the growth of the beard, the growth spurt is what is need to be identified, and you identify them by riser sign, which is the fusion of the iliac crest apophysis, or by the triradiate cartilage. So these are the things which you need, and you need a whole length X-ray and corrective X-rays. You may need MRI and CT scans according to case. You have to identify the type of the curve, the rotation of the curve, where it is located, where is there a pelvic obliquity there or not, and what is the amount of cosmetic appearance, and what do you want to correct, and what do you want to leave out. So the cutoff value is 40 to 50 degree, and that's how we decide what we want to do further. Say if a patient presents to you after a maturity age, then you have a curve which is say 40 or 50 or 30. You have to make a decision whether you have to go ahead further or not, and the decision is based on this thing. So a curve of more than 50 degree in thoracic is likely to progress. A curve of 30 and less is, sorry, 30 and more can progress in lumbar. So you need to know this thing. It is very much important. The degrees of curve, it would vary thoracic and lumbar. Scoliosis, the most important red flags that should be an urgency to bring to the notice would be atypical curve pattern, which is not very clearly seen, rapidly changing degrees of curve, painful scoliosis, and abnormal neurology. Degenerative scoliosis is also a common entity now with more and more life expectancy, and it can present with claudication, neurological problems, and increasing deformity, which itself may need addressing in terms of surgery or conservative management. And add-on would be osteoporosis. The natural history of most of the deformities of the idiopathic type is favorable, and or congenital also is favorable, and only 10 to 20% is what you need to identify from the whole of the lot and need a urgent attention or a planned approach to avoid catastrophic, big, treacherous surgeries and deformity correction with high risk. So the treatment historical, all we know about these things, and you can brace these patients. You can give a cast to young patients, but our climate does not allow this. Patients don't tolerate. They've given so many number of cast, patients just remove at their home and they don't return back to us. So that's a problem with body cast in case of scoliosis. So our climate does not allow it. Bracing can be given, but it is to be enforced that you need to wear it for 16 to 18 hours to make it effective, and that is for certain curves only. Exercises is as such good, and for any deformity also, it is not going to correct, but it will keep your back supple and strong. Surgical intervention is usually needed when the curve has gone more than 40 degrees. Then only you need to do it, and or if there is a neurology, and if you have to do a surgery in the earlier age, you have to know that there may be more and more surgeries that may follow in that kid also. It's not the end. Say at maturity, if you have done a surgery, that is going to last for life. But if you have operated at a very young age, say 3 years and less, we don't try to operate. We never operate. So usual age is between 3 to 8, and lower the age, more the number of surgeries can come in the future. And surgical goals is to arrest as well as at times decompression also. Like this is preoperative scoliosis, operated, it gets corrected significantly. The correction of the curve is limited, but the clinical appearance becomes too good. So even for a stiff curve, we can get good outcomes like this. This is kyphosis of 80 degrees, and this gets corrected. You do a VCR. These are high-end surgeries. This patient is now married. He's 22 years old now. Surgery is definitely risky, and a bigger surgery and a high-end surgery of the spine surgery. And how you get away is that intraoperative neuromonitoring has to be the standard of care in this, and if patients going to a doctor should ask for that, we need intraoperative monitoring. Mesonex, again a bone cutting tool, is a high-end instrument which helps in having very precise cuts, and this is O-arm. We have two O-arm machines, the navigated surgery, wherein you can precisely plan your screws. Like this is a 19-year-old AIS had operated this, and this patient, if you can see, putting a screw in so thin a pedicle, how much precise it can be with a navigated O-arm guided surgery. So this will increase the perfection to nearly 99.99. So we should think about it. After the surgery is done, we can take x-rays per operative and align it and see everything is proper or not, and we can readjust again. So whole length of the images can be stitched and understood. So this is how we can go correct, have outcomes. Complications, as expected, can occur and can be vast neurological deficits, infection, injuries, pseudoarthrosis, additional add-ons, proximal add-on outside the construct, or lower add-ons outside the construct, which may change the sagittal and coronal balancing again, and it can cause problems also. It is, but they're not frequent. And other deformities also is there, like traumatic deformities, the tuberculous deformities, late tuberculous deformities, neurofibromatosis, kyphosis, scoliosis, rare syndromes, ankylosing, Scheuermann's, C2 and C2 instability, spondylolisthesis, traumatic, osteoporotic deformities. These all are there. This all comes under the heading of deformity, but where our topic was just limited to only the AIS and the congenital things. And the most important thing what you need to do in deformity is that ruling out neurological problem, ruling out the progression chances. You have to predict how much it can progress and cause problem. Watchful neglect and conservative would work in 80% of cases. Predictable safe surgery is always now possible at the way. Regenerative is a whole different group of problem, and it needs a different treatment. Thank you very much.
Hello everyone. Today I will be speaking about ankylosing spondylitis. There are various kind of spondyloarthropathies. One is ankylosing spondylitis. The other is psoriatic arthritis, enteropathic arthritis, reactive arthritis, undifferentiated spondyloarthropathies. Let's understand meaning of the word. Ankylosing means fusion, which reduces the flexibility of the spine, and spondylitis means inflammation, which increases the pain. So both together, ankylosing spondylitis means the condition which fuses the spine and produces inflammation and pain. So ankylosing spondylitis can be defined as chronic inflammatory disorder of the spine and sacroiliac joints characterized by pain and stiffness of the back. This disease is not new. It was found 5,000 years ago in Egyptian mummies. The epidemiology of the disease says that it is seen more in male than the female, and usually in younger age group between 15 to 25 years. The cause of the disease is said to be a triggering of HLA-B27 antigen. Even though it is found in many people, out of that only 50% of the people get this disease. The symptoms of the disease are insidious onset, backache, referred pain, stiffness, worsening in the morning. The pain increases in the morning, worsening after inactivity. So the triggering factor is inactivity. Whenever person is inactive, it increases the pain. Polyarthritis, where the sign can be seen with flattening of lumbar lordosis, where the neck is forward, hips and knee are slightly flexed, tenderness around dorsolateral junction and bilateral sacroiliac joints, loss of extension, chest expansion reduction, wall test positive. So this is how the patient looked like with the lumbar lordosis reduced and dorsal kyphosis increased and stooped posture with knee and hip flexed. The X-ray finding includes bamboo spine, ankylosing fusion. So normally one can see this disc space on X-ray cannot be seen over here, and it has nodes like bamboo at each discal level, and this is how the X-ray looks like, bamboo spine. On X-ray, sacroiliac joint erosion can be seen. The CT scan may show fused sacroiliac joint like this. The MR finding will show hyperintense area at sacroiliac joint showing sacroiliitis. Romanus sign can be seen at end plate level on MRI. The treatment plan at Stavya we follow is medical management, physiotherapy management, ergonomics, and surgical management. The medical management includes NSAIDs to reduce the inflammation and pain, sulfasalazine and disease-modifying anti-rheumatoid drugs to diversify the disease and reduce its symptoms, anti-inflammatory analgesics and anti-TNF alpha to reduce the reaction with antigen antibody, The goal of physiotherapy will be maintain the flexibility, as this disease affects the flexibility most, to maintain the lung capacity, as because of this disease the lung capacity reduces. Prevent deformity by doing some exercises of extensor muscles. One can keep the posture in erect position and prevent the deformity. Maintain a physical activity level. A general activity level should be maintained. The disease comes with morbidities, and hence one need to learn to live with it. Like, for example, if someone cannot extend the neck and hence they are not able to drink the full glass of water, they can use straw to drink the water so they can complete the full glass. The same way, if one cannot bend forward and grab the things from the floor, they can use clutchers to grab the things fallen on the floor. If because of the stiff neck, the neck is forward head and forward flexed and they cannot extend, so the patient can use a thick pillow or two pillows to keep the neck comfortable and painless. The same way one should use revolving chair rather than turning from the back because of the stiffness. The surgeries are advised in case of morbid deformities which restricts the daily activity of living, to improve the chest expansion if it is compromised, to stabilize fracture segment if the patient has got fracture which is called as Anderson lesion. To stabilize it, we advise surgery. To gain the decompression of the spinal canal, if patient has a compression or compromised spinal canal and cord compression, either myelopathy or radiculopathy, we advise surgery, etc. My take-home message will be symptoms increases with inactivity, so remain active. Activities like swimming, brisk walking and cycling gives good relief. Such activity can help to relieve the pain. Active, fast progressive conditions cannot be cured to 100% because it usually comes off and on. So try learning to live with it and do your daily activity with some modification. Use common sense approach rather than not doing, find how to do it. So any activity which increases the pain or which cannot be done because of the disability can be modified with the help of ergonomics. Dhanyavad. Thank you.
Good evening, viewers. Today is the last webinar, which I would call it as a conclusive webinar. We have had a series of few webinars related to the educational activity only, and today we have the conclusive webinar in which we have in 10 minutes concluded all the spine ailments in short and with the red flags. Now today has been our long day, as we had a big tumor case, and that was the transthoracic and the posterior surgery we had. So I would like to start the question with Dr. Devanand, who is our team member who is doing the onco-spine cases in our team. Would like to know about the teamwork, Dr. Devanand. How do you, stress about the teamwork, which you already have mentioned in your talk?
Yes, sir. Good evening, all viewers. Yes, as I mentioned in my last two slides, tumor work is always a multidisciplinary approach because most of the tumors are usually identified in a later stage and patient usually turns up very late to us, in which it's not directly visualized, and most of the tumors, they enter into the thorax or into the sacrum pelvic cavity like this. So as a spine surgeon, we have few limitations as we are not completely exposed to many of the internal thoracic cavity or internal pelvic cavities. So we take access of an onco surgeon. Sometimes we need onco head and neck surgeons, onco surgeons who are trained. So we, as a surgeon, it's always a teamwork. not only in the intraoperative, we need neuromonitoring, which is also a main thing which will tell us about the spinal cord status. Along with that, post-operatively, we need a lot of input from oncophysician, radiologist, radiotherapist. So in this way, it is a multidisciplinary approach not only in the surgery but also after the surgery. So in my view, spine surgeries, especially the tumor work, is a multidisciplinary approach where we need an access of oncosurgeon, spine surgeon, sometimes neurosurgeon, yes, a neurophysiologist, where in our team, our chief physiotherapist, Dr. Biju, he does all the neuromonitoring work. And even after the post-op cases, we need help of all these teams. So it is a multidisciplinary approach, I say.
Yeah, okay. The question to Dr. Ravi, there is a question from the audience and there are a lot of questions from the lumbar spine. Why few patients are unhappy after the surgery? One of the most common question which is seen on the screen, why people are unhappy after the particular lumbar spine surgery?
Yes, sir. So this notion is there particularly after degenerative surgery. The thing is, the patient and the doctor needs to discuss, and the patient needs to understand what we are dealing with. When we are dealing with a degenerative lumbar spine conditions, we are not going to. It is not a disease which we are going to reverse or completely eliminate. It is a degenerative, ongoing, age-related process which we are not going to stop. However, some particular problem which has arisen because of that, like a neural compression or a nerve root compression which is causing pain, that particular reason can be treated, that particular cause can be treated. We cannot stop the overall process of degeneration. Once the patient understands this, his expectations are realistic, this unhappiness would not arise.
Yeah, I think another thing which one probably may need to add is the late coming for the condition, then, yeah. The question to Dr. Shivanand, can you talk about the sarcopenia? We know that, the bone, the muscle also have tendency to go down as well. So I think, everybody probably we should be informing them.
Yes, sir. As the aging process occurs, along with this deficiency of calcium in the bone, which leads to osteoporosis, the same way, because of decreased activity, there will be decrease in the muscle mass, which is active muscle, lean muscle mass, what we call it. There will be decrease in the lean muscle mass, which will add to the fragility of the patient, that is fractures, imbalance, other things. So along with this osteoporosis treatment, this sarcopenia, that decrease in lean muscle mass, needs to be also considered, and appropriate muscle strengthening exercises and high protein diet needs to be added to the patient's lifestyle.
Yeah, thank you. I think sarcopenia and sarco-osteoporosis both are friends, and they walk with each other, and then they are all sort of age-related disease like diabetes, mellitus, and hypertension. Both same way, these two are going to bother us, and aging population is going to be harassed by these two duet or friends, you can say. Yeah. We have named the sarcopenia as the silent sucker. It sucks the muscle. Anyway, question to Dr. Devanand. The tumor cases which we have been operating, so do they really need some follow-up? We are talking about all the three groups, intradural and the bony tumor, and so what sort of follow-up we should be advising them?
Yes, sir. That's actually a very good question, because it depends from case to case. I can say that if it is a primary bone tumor, the dictum at Stavya is we always take post-operative CT scan and a post-operative MRI scan, and intraoperatively we send the patient's tumor for a biopsy. So these three things will dictate the surgeon for the frequent follow-ups. For example, if it is a primary bone tumor where we have removed completely and we are sure of the diagnosis that it is a benign tumor, we may need a follow-up 3 months, 6 months, and then 1 year, and then we can stop. But if the tumor is something which we have not removed, or we could not remove, or it is irremove, I mean, we cannot remove it completely, then we need a more follow-up, and post-operative radiotherapy, chemotherapy, and follow-up every 3 months till 1 year. After then, 6 monthly, at least for 5 years. So I would primarily say that it depends from case to case, and few of the cases are like metastatic tumors where the patient has very limited lifespan. Then we need a careful follow-up not only with us but also with the oncophysician.
Yeah, thank you. I think very well addressed. But particularly intradural tumors, we need regular follow-up as well because they have chances of recurrence.
Yes.
The question to Birju bhai, the ankylosing patients 1, 2, and 3. These are the 3 things they should do all the time. Can you just share your view? What are the things that they should do every day?
Yeah. So they should actually, whoever has ankylosing spondylitis should always try to be in a good posture. So even if the spine fuses, it fuses in a good posture. Second, the lifestyle should be very active, not very active, but at least optimum active, that the disease can be controlled to some limit. And ergonomics, so they do not end up breaking their spine in odd postures and odd conditions, and prevent falls.
Yeah, and perhaps the deep breathing exercise as well, as you mentioned.
Yeah, certainly that. Yes, sir.
Yeah. Dr. Ajay bhai, this is a burning question which is coming from all over the place. So what are the advantages of the gadgets that you have found in these high-end surgeries? Because you have been operating 8 hours, 10 hours in deformity cases. So what advantages you could see with these gadgets? You're muted. You're muted. Unmute, please.
We have gadgets for meeting different aspects of the safe spine surgery, and these are technical instrument, and these are also the computer assisted surgeries, or say artificial intelligence guided surgeries. So if we go step by step, evaluation itself is a big thing. With all these evaluations, there are modern evaluations which are going on, which includes all the CT scan, MRI evaluations. With that, the patient is completely prepared. Even the cardiovascular to the medical fitness, is a gross spectrum of things which is done. Then comes the role of the per-operative work, wherein the anesthesia machines and the anesthesia team that has got a very big role to make this safe, to guide the surgery through. We have the best of the anesthesia machines, which we were the first one to acquire these machines, say 12 to 15 years back itself. So we command good anesthesia because of our team and machines. So we have safe anesthesia. Secondly, what is important is to maintain and deliver a completely normal neurology of the operated patient. Because these are high-end deformities, there are always chances of neurological deteriorations. So herein comes the role of intraoperative neurophysiological monitoring, wherein Birju bhai is the team leader, he is the neurophysiologist at our end. And the machines, we have 2 machines. They detect even the smallest of the alerts for any losing neurology and give you time to react. Say, earlier we used to do a wake-up test for surgery, right? We finish off the surgery, lighten the patient from anesthesia, and then check by moving the feet movements that he or she is having a normal neurology. And if found anything wrong, then we may correct this. But in that, there is a long time gap which is there. This is live. This is in time. So this is progressive monitoring, multi-modal monitoring. It has got multiple aspects of it. So we are able to detect it very timely for a safe spine surgery. Then we have technical instruments. So technical instruments like we are having burrs, we have Mesoneck bone scalpel. You can actually sculpt the bone, you can cut through, you can so precisely cut without ever causing a damage to the neural tissue. So that is a very big thing. We have good number. We have 3 burrs. We have 2 Masonic scalpels, multiple handles. That is very useful, and it makes the surgery speedy also. So you are saving the anesthesia time, you are saving the blood loss, you are making the surgery in general anesthesia more safer because the duration gets shortened. So this is another thing which is there, the Masonics. Then we have the O-arm, per operative O-arm, and the CT scan. The CT scan, we all know, that gives the precise anatomy of the bone. So if you combine the anatomy acquired by the CT scan into the navigation, so that makes the preciseness of inserting implants so precise that there is hardly any mistakes which can occur. At the same time, you can get images after putting the screws and things, and you can again reconfirm. After having corrected a deformity, per operatively you can have long cassette stitched images to again see the alignment what you have got. And this adds to the technology too much. So these are the things which has given us immense confidence, immense outcome to all the complicated deformities which comes to Sterway.
Yeah. Thank you very much. We would like to conclude this series of webinars. For the cervical spine, I would just add only one thing. There are questions, which say that what are the exercises we should be doing, which I have shown in my slides. So these are the things that we should really follow in order to prevent the neck pain. And if you have neck pain, and if you are cured of the radicular pain, then probably you should continue those exercises in order to prevent the recurrence. Now, this is probably, something where we really need to end. I'm thankful to my colleagues and the viewers for sharing their spending the time with us. I'm thankful to Shreya Gupta from Torrent and the Torrent company for giving us this opportunity to share our knowledge. And thanks to Dimple Ma'am and Virtual Bucket for giving us this platform. We at Sterway usually pre-COVID era, where sort of OPD cases, we used to say about 15,000 new cases, but the number that we operate is only 1,500. So it's only 10% that need surgery overall. So 90% of the patients, those who come for the outpatient consultation, they all are managed conservatively. This is something which I would like to share this data. That means, anybody who is advised MRI, it is not for the surgery. It is to make the diagnosis perfect. And in spine surgery, the word which we all use is the clinico-radiological correlation. So if the clinical symptom, they match with the radiology, then only we say that this is something which is good for you. This is something that is needed for you. And particularly, we always try to conserve the management point of view. So we try to sort of tell them that, this is something which is required, and we teach the natural history as well on many occasions to the patient. These videos which we have recorded are available at the sterwayspine.com website. So you can use it. We also have one additional thing in the appointment is the symptom calculator. So this calculates the symptom as you keep answering, and then we know that how severe your symptoms are, and then we can give you the appointment according to our specialist team, and we can give you the appointment early as well. So use this symptom calculator, use our appointment system as well. Thank you both Torrent and Virtual Bucket, and thank you very much for all my colleagues, friends, and thank you viewers. Over to Shreya.
Thank you so much, sir. Would like to take this opportunity to thank all the participants and all the speakers today for this interesting and knowledgeful session. Thank you to all the audience for joining us today for this Thursday evening. It has been a wonderful journey. The Spine Series Knowledge Karwa definitely shall continue. And as Dr. Bharat said, that these recordings are live and viable to all of you on YouTube. And we also circulate the link of today's session post the webinar. And you all can subscribe to Sterway channel on YouTube and Facebook for regular updates. They do a lot of patient education series and programs. Today was the ninth and the concluding webinar of the series, the Spine series for us. Shelcan feels immense gratitude to all of you. A warm thank you to Savya team for giving us this opportunity to contribute to your noble educational endeavor. Thank you, Dr. Shivanand, Dr. Ajay, Dr. Bharat, Dr. Devanand, Dr. Ravi Ranjan, and Dr. Birju. It has been such an honor. A special thanks also goes out to Miss Payal and our beloved Amita ma'am for their tireless efforts throughout the series. They always say the most beautiful thing about learning is that no one can take away from you. And this is what Savya Spine series has given all of us. Good night to all of you. Stay safe. Thank you.
Thank you. Thank you.